Okay.
Okay, so good morning, Bob.
Hey, good morning and
And
welcome.
yeah, thanks. Excited to have you come on again today. So you got a final segment for us with some final tidbits. So I'm just going to let you take it away.
Great. Okay. Yeah. Hello and welcome to all. And yes, today we are going to kind of finish up a series that we've been working on. So just for those first timers, perhaps, my name is Bob Fury. I am a pharmacist. And we are going to close out this section with the last three groups of medications that deal with the motor symptoms in Parkinson's disease. Now, these drugs don't actually fit into the classic categories that we've seen. For instance, there's dopamine and dopamine agonists and enzyme inhibitors, which we have spoken about in the past. These three don't really fit any place, so they kind of group them into oddball places, but they are used occasionally for different reasons, and we'll discuss those as we move forward. Now, the three categories we'll be covering today are a group called anticholinergics, a drug called Amantadine, and a drug called Adenosine. Now, we've talked about anticholinergics before, but I'd like to clarify exactly what we're dealing with. We'll start with them first. There are only two drugs in this category. The first is a drug called Artane, which is a brand name. It has a lot simpler than its generic name. Its generic name is trihexyphenidyl. The other drug is a brand name called Cogentin or benztropine. The brand names you would be hard pressed to find anymore. They've been around for so long, the manufacturers don't even make the brand names anymore. So if you were to get a prescription for it, you would only see it by their generic names, which would be benztropine or trihexyphenidyl. So let's just simply define what an anticholinergic is. Just breaking down the name itself, we've got anti meaning something obviously that stops or prevents or inhibits or blocks or something like that. And then we have cholinergic. What is a cholinergic? So very simply put, it's a reference to any drug that acts or mimics the actions of a chemical messenger called acetylcholine. Now, we're always talking about dopamine when it comes to Parkinson's and smooth and coordinated movement. But quite frankly, there are many other chemical messengers. Acetylcholine happens to be one of them. And the best way to really look at it is under normal circumstances for normal movement, we have a level of dopamine and we have a level of acetylcholine. And typically these are within reason, they are in balance with one another. So what happens is, as we all know, in Parkinson's, we get this decrease in dopamine production. And as a result of that, now I've got this extended level of acetylcholine floating around that doesn't match up with my dopamine anymore. And it's that excess acetylcholine causes, I guess the best way to call it is a hyperexcitability to the muscles. As a result of that, you get this jerky, unsmooth, uncoordinated movement, frequently even tremors with that. So the concept of using an anticholinergic would be something that goes against acetylcholine to block its release or production. So now I can bring down that level of acetylcholine to match the decreased levels of the dopamine that I have. And now they're back in sync again. And that's really the goal that we have with anticholinergics. Now that's easier said than done, and they definitely have some issues. One of the first issues that they have is side effects. The problem with anticholinergics is they are best suited for, I would say, the younger patients because of these side effects that we'll be speaking about in a moment. And if I had to define a number or put a number on an age bracket, which I don't always like to do, but I think probably age 65 and younger would be the most appropriate for the addition of an anticholinergic like this, simply because of the side effects. You'd be hard pressed to find a neurologist that's going to use these drugs in a patient that, let's say, is 75, 79 years old, because of some of the added anticholinergic side effects that they're going to get with that. So while we're there, let's talk about that. Let's discuss some of the side effects and why are they a concern in the older population. Anticholinergic side effects are not just limited to those two drugs. A simple example of that is an over-the-counter product called Benadryl. Benadryl has been around for years and years, has all kinds of uses, but it does have anticholinergic side effects. Classic ones are, first and foremost, is usually a dry eye. Now, that doesn't sound like a big deal, but for a Parkinson's patient, it is, because they have dry eye to begin with as part of Parkinson's. So we're only going to add to that problem for them, and that can be extremely problematic and uncomfortable for them. And if not treated properly, sometimes this can lead to other infections and inflammation in the eye. So that's of concern. Dry mouth is another classic side effect of this group of medications. Now, initially, some patients may look at that as a blessing because they drool or have excess saliva. So one would think, oh, this could be a great thing. I'm going to dry up that excess saliva. But just to be clear on that point, Parkinson's patients don't actually produce more saliva than anyone else. The problem why they have so much saliva is they don't swallow enough. Of course, swallowing is a muscle-controlled movement. And like all muscle-controlled movements in Parkinson's, they're slow or malfunctioning for some reason. So by not swallowing, they get this accumulation of saliva in their mouth. If we give them an anticholinergic like this and they get dry mouth, they're less likely to swallow even less because they don't have as much saliva anyway. So swallowing is a big deal for them. And so that's not a good sign, aside from the fact that the oral cavity is designed to be a moist environment. We need a certain level of saliva for bacterial protection and normal flora in the mouth. By eliminating that, it subjects them to bacteria and infections. Conditions called xerostomia begin to develop. So that's not a good thing. Hallucinations, and this is a big deal, especially in the older population. You don't usually see hallucinations in the younger patient, but you definitely do in the old. And I'll group illusions, delusions, and hallucinations all into one category because they all seem to intermix. And illusions are interesting for Parkinson's because they don't always start off as seeing little green men walking around on your ceiling at night. The typical hallucination in a Parkinson's patient usually starts off something very simple, where usually it's in a dimly lit room. In the evening, you're watching TV, the room lighting is down, and all of a sudden, out of the very, very periphery of your eye, you see something go by, and you look and you go, what is that? And you don't see anything. There's nothing there. And a few minutes later, maybe on the other side, on the very outskirts of your periphery, you look again, nothing there. No matter how fast you turn, you never catch it. You never see it. But it's usually, believe it or not, it's usually a furry animal, a cat, not so much a dog anymore. A lot of people complain of a cat or a small child is what they claim to see. But the key there is there's no stimulus. There was never anything there. And that can progress. Those hallucinations can progress. And they can become really problematic for some patients. I've watched a bunch of interviews with psychiatrists talking to patients who are having hallucinations. And it's very interesting to see. Some of them don't mind it at all. They live with it for years and years, and they don't find it, they're not threatened by whatever it is they're seeing. They stay around, they're always there. Some of them have hallucinations that there's army men or whatnot. So that's a hallucination, as opposed to an illusion. An illusion is a misrepresentation. And we've all had this. A mirage is an illusion. Driving down the road and you see a body of water, that's an illusion. But the difference is there was something there and your brain didn't quite make out what it was. So it filled in the blanks of what it thought it was until you looked at it again for a little longer. And then it clicked in what it actually was. But the important difference is in a hallucination, there was never anything there, as opposed to an illusion where there was something there and you just misrepresented it. And of course, delusions are those probably the worst of all of them because they can be severely problematic. Delusions are a belief that something is going on. And unfortunately, many times that delusion is infidelity. The patient believes that their spouse is having an affair or is unfaithful to them. And with a delusion, no matter how much evidence you present to that patient, they still, you can't unprove it. They're going to have that delusion no matter what. The spouse can say, how can I be anywhere else? I'm with you 24 hours a day. I can't, it doesn't matter. They still believe what they believe, or they believe that someone's stealing money from them, or there's the FBI is tapping everything that they have. These are side effects that absolutely unequivocally need to be addressed in their early stages because they are resolvable. Don't let them get to the point where they're unresolvable or problematic for you. They do happen, but your neurologist is certainly well trained and well equipped to handle them and eliminate them as quickly as possible. So that's one that really needs to be spoken about.
Yeah.
And the last one, side effect wise for anticholinergics, is sweating. These drugs have an ability. One of the roles of acetylcholine is to be in control of our sweat glands. Doesn't seem like an important thing, but we're down here in Florida, and one of the ways of thermoregulating our body temperature is through the process of sweating. And if we block that ability, that's one way our body cools itself. So if we inhibit that reflex, it's very possible heat stroke can be an issue. So it's very important if you are on these drugs to make sure that you stay well hydrated, you're very careful about perspiring. And if you find that you're not or very limited, again, this needs to be discussed with your physician, and they can very easily make adjustments for that. But it's important to be cognizant of that. So that's our anticholinergic group. Next group is, it's not even a group, it's a single entity. It's just simply a drug called Amantadine. And Amantadine has a very rich history. It started off as an antiviral drug back in the 60s for the Asian flu. It grew in popularity again in the 70s for influenza type A. Now, there's a lot of anecdotal information how it made a transition from an antivirus drug to a Parkinson's drug. But from what I've kind of been able to pick through the literature, it seems like a woman, and I emphasize a single woman, who was a Parkinson's patient back then and had developed, I believe it was influenza type A, was taking Amantadine and noticed that her Parkinson's symptoms had dramatically improved. And after she went back to see her doctor, and after she was pretty much cured from the virus, she was really begging him can I stay on this because my Parkinson's symptoms have been great. So story has it that he talked to another colleague and whatnot, and it kind of spread throughout the community to the point where eventually in the mid 70s, the FDA finally gave it an approval for its use in Parkinson's. Now, this is definitely not going to be a first-line drug of choice. It could be used for the slowness, stiffness, and the tremor, but it's certainly not as a first-line drug of choice. This would probably, and if it was, it would be something that would be used in the younger population who got Parkinson's at an early age with mild symptoms. Again, levodopa has always been and still is the gold standard for treatment, but this could be used early on. The interesting part about Amantadine is, unlike other drugs, that the more you give it, the less dyskinesia you get. Where usually most drugs, the higher the dose we give them, the more likelihood of dyskinesia is developing. So with that thought in mind, it really became very popular in the treatment of patients who were experiencing dyskinesias for prolonged periods of time or frequently throughout the day. It could be used for the tremors and the stiffness, but nowadays I believe it's mostly used for dyskinesias. And there's three formulations of this. The first is the standard immediate release, which is called Symetril. Again, I doubt very much you'd be able to find a brand name Symetril on the market anymore. It's been around forever, but it would go by its generic name, which is Amantadine. And it's an immediate release tablet. It's dosed multiple times throughout the day. And it stayed that way for many, many years, all from the 70s all the way up until 2017. A bunch of years have gone by, and they finally kind of reinvented Amantadine. And in 2017, the FDA came out with a product called Gocovri. This is a drug that is a long-acting version of Amantadine. It's given at bedtime, only once a day at bedtime, and it's a capsule, which is convenient in the sense that you can open it up and sprinkle the contents on food for patients that are having difficulty swallowing. Again, side effects are going to be almost the same as what we just discussed with the anticholinergics, pretty much the standard for all these drugs. So we won't go over all of them again. But this is very popular for dyskinesias, and it's nice that it's, as opposed to the immediate release, which is taken several times a day, this is a bedtime dose with the concept of taking it at bedtime. You can wake up in an on state and get your day going right away. 1 year, that was 2017. 1 year later in 2018, another product came out called Osmolex. This is an extended release tablet. And this is taken in the morning. This has a very interesting delivery system that's worth talking about. It has 4 layers to the tablet. The outer side that you see is just the coloring of the tablet. The next layer, that gets dissolved almost immediately once you swallow it. Then the next layer is the immediate release form of Amantadine, so that you get that quick jolt within that 35, 40 minutes. You're getting a little bit of Amantadine released. When that second layer is dissolved, it exposes what they call a permeable membrane. I kind of look at it as kind of a mesh coating, that inside that mesh is a core of long-acting Amantadine. So what happens is the water from our intestinal tract seeps through that mesh covering to that core, liquefies it, and then this is the interesting part. There is a laser drilled hole in the tablet. You could really see it if you look close enough. And I guess that's how its name is Osmolex. So I guess by osmosis, that little laser drilled hole pulls out the core, the long-acting Amantadine from the tablet, and allows it to come through that one tiny hole throughout that 12 or 24-hour period. So that's how they got to use an extended release version, by using that kind of technology. That's wonderful technology, but I'm going to tell you, here's one of the inherent concerns. I've seen this technology used before over the years. I've seen it in a potassium supplement uses that technology, and there's a blood pressure or cardiac medication that uses the same technology. As the body kind of draws out all of the contents from the tablet, you're left with this empty shell. That empty shell appears in your stool. It's not digestible. So I've often gotten a call from those other people, of the other tablets that we use for the potassium tablets, where patients would call and say, hey, I don't understand this. I take the pill just like my doctor told me to, and then I see it in my stool. So what is it, not working? Did I not get it? And of course, that's not the case. That shell is completely empty inside. What you're just seeing is the outer contents of it. But it can be concerning for a patient who first goes on and says, hey, this is what a waste. I'm taking these things, they're going right to my body and not doing anything. when in fact that's really not the case at all. So if you're on that, or if you're about to go on it, consider that as one of the things. It's a harmless side effect. It doesn't mean anything.
Okay.
The final and last group that we're going to talk about is adenosine. And this is very interesting only because this is a new approach to Parkinson's. There's only one drug in this category. It's called Noriance is the brand name. The generic name is called istradefylline. And it came on the market in 2019, probably didn't even hit the shelves probably till early 2020. So there can't really be a lot of patients on this yet. But it's used as an add-on. It's not approved for monotherapy at this point. I believe at some point it will be, because it's an interesting approach. And it's very complicated, but we've learned finally, after over 50 years of focusing on dopamine, we're now finally focusing on other neurotransmitters, and adenosine is one of them. And the best way to describe it is, and these are not in my words, this is really, it's so complicated, I can't even follow how this works, but the manufacturer has a very cute way of describing it. And they make reference to the gas pedal and the brake pedal in your car. So if you look at dopamine as the gas pedal and we apply pressure to it, the car moves very smoothly in the direction you want it to go. The more you put on the pedal, or the more dopamine, the better and faster you go. Adenosine is like the brake. When you want to stop the car, you push on the brake, and very slowly and in a coordinated fashion, the car comes to a halt. So pretty much like we discussed acetylcholine before, adenosine and dopamine are the yin and yang to movement. The dopamine wants us to go, and the adenosine wants us to stop. What happens, of course, in Parkinson's, as we said, we've got this decreased level of dopamine, and now we've got all this adenosine, or all this brake motion going on when we want more gas, but we're getting more brake instead. So what Noriance does, this is an adenosine receptor antagonist, meaning it blocks the release of adenosine. So here again, we've got our decreased levels of dopamine, and if we can block the release of adenosine versus dopamine, we can, using Noriance, we can bring that level of adenosine back in check with the dopamine. Or in other words, we can balance the brake and gas pedal so that we're getting smooth and coordinated movements. And that's essentially, I mean, it's a very complex process, but that's as simple as you're going to get for that. And again, the jury is still out as far as effectiveness. The drug hasn't been out for very long periods of time, although it did do very well in phase 3 trials. What happens very often, those trials are with small populations of patients. Then when the drug gets into the general population or the global population, that's when we begin to see things. That's the best judge as far as how effective it's going to be. But right now, it's out there. It is available. I've already spoken to a couple of people here that are on it. So I know it's available. A couple of interesting side effects that I need to point out. It has the usual side effects that we've spoken about before, dyskinesias, insomnia, nausea, and whatnot. But it does have two interesting drug interactions. The first is grapefruit. I don't really talk about that, but there's a lot going on with grapefruit and grapefruit containing products. So far, I haven't run into any issues with other Parkinson's medications and grapefruit, although I would still advise most patients to avoid it anyway. But this is a clear one that definitely has come to light. If you drink grapefruit juice or consume anything, a grapefruit containing product, the problem here is grapefruit is a very powerful inhibitor of the enzyme that breaks down adenosine. So if you inhibit that enzyme, the adenosine level goes unchecked. And as it begins to rise, remember, that's the brake as opposed to the gas pedal. So now I've got elevated levels of adenosine doing what adenosine wants to do, and that's to slow the movement of everything. Not to mention having that high level with no means of clearing it from our system is going to amplify every single side effect that's associated with this drug. That can be dangerous. So no, and it's not even, should I space it out? Should I, wait a while? No, it's do not take it at any point in the day if you're on Norians. And the final kind of odd drug interaction or food drug interaction, if you are a smoker, if you smoke at least 20 cigarettes, which is basically 1 pack a day, or use some kind of nicotine product like chewing tobacco that would equate to about a pack of cigarettes a day, this does the exact opposite. Where grapefruit juice inhibited that enzyme, the smoking, probably the nicotine, stimulates that enzyme. And now what's going to happen is you're going to break down the Norians even faster. And it's so substantial that almost 50% of the dose is lost if you are a smoker. So instead of starting off with the regular 20 milligram dose of Norians, patients who smoke at least 1 pack of cigarettes a day are recommended to start at 40